Hello and welcome to today's webinar. I am Trevor, the Communications Manager for the Canadian Cancer Survivor Network. Thank you to everyone attending today's webinar. This is our second in our 2024 series. If you are new to our webinar, a little background on our group. CCSN works to connect patients, survivors, and other stakeholder groups with decision makers and the wider community to engage in discussion and to act on evidence-based best practices to alleviate the medical, emotional, financial, and social costs of cancer. To learn more, visit us at survivornet.ca. Now, this webinar is being recorded and will be available on YouTube, and a link will be provided with the email you registered with, along with a link to the slides provided in this presentation. We'll add a quick Q&A session at the end, but if you would like, put in your questions in the chat at the end, and that should be at the GoToWebinar menu on the side, right where the questions part is. And now we are going to get to our presenter. Unfortunately, we will not be joined by Craig Cause's founder and director, Stephanie Cordon-Oldrive. However, in her place, we will have Erin Ranger, patient support manager and healthcare manager with Craig's Cause. So without further ado, I'd like to turn it over to Erin for her presentation, Pancreatic Cancer, an Overview.
That's great. Thank you so much, Trevor, and thank you everyone for coming out and being here for this presentation. As Trevor said, my name is Erin. I'm the patient support manager and healthcare manager at Craig's Cause Pancreatic Cancer Society. I'm really excited to be here today and just sort of give a little bit of an overview of pancreatic cancer, and just sort of give a little bit more information on pancreatic cancer, and then also just share a little bit about what we do at Craig's Cause and how we can help. So if you can go to the next slide, Trevor. So just an overview of what we'll talk about today. So we're going to go over signs and symptoms, types of pancreatic cancer, statistics, stigmas and myths, best practices, treatments, supports, and the future. Next slide, please. So starting off with signs and symptoms. So signs and symptoms of pancreatic cancer, they're often sort of something that you can write off as something else. So it might be something like, oh, you have some back pain, and you think, oh, I probably just tweaked something, or, oh, my urine is dark, I'm probably just not drinking enough water, things like that. It can also be abdominal pain. There could be unexplained weight loss, yellow skin or eyes. So patients often turn jaundice all of a sudden. And they don't know why, and it's sort of unexplained. It's usually painless. There can be changes in stool, so stool might become like sort of fatty or like change color and become quite pale. There can be new onset diabetes, digestive problems such as indigestion, nausea, lack of appetite, and mood changes. Next slide, please. Perfect. So there's a few different types of pancreatic cancer. The most common for sure is exocrine. That's typically known as pancreatic adenocarcinoma. And that takes, represents about 93% of pancreatic cancers. Unfortunately, it's the aggressive one. It's fast growing, and it is the one that is usually found at stage 4. Again, going back to the symptoms and signs, often people write the symptoms off as, you know, just again, like back pain or dehydration or something like that. And then because they don't get those assessed early on, they're not able to sort of find the cancer when it's earlier, and then it's found usually, again, at stage 4 once they've turned jaundice. And there's a blockage of tumor blocking the duct. There's also neuroendocrine. So this is a less common type of cancer. It's about 7% of the pancreatic cancer cases, and it's a lot slower growing. So people typically live a lot longer with neuroendocrine cancer, and this is in the islet cells. So it's endocrine. It's responsible for more sort of like hormones and insulin. The next one, is the less common or rare one. So we have the intraductal papillary mucinous neoplasm. It's commonly known as IPMN. These are sometimes start as non-cancerous or benign, and then can become cancerous. There's also acinar cell carcinoma and mucinous cystic neoplasm with an invasive adenocarcinoma. Quite a mouthful. Next slide, please, Trevor. So for pancreatic cancer, so I'm sure many of you have heard of the Whipple procedure. So this is a procedure that it takes place to remove part of the pancreas, to remove the tumor that's in the pancreas. It's a really involved surgery. It takes a long time, quite a few hours. And it removes part of the stomach, the duodenum, the gallbladder, obviously part of the pancreas, usually the head of the pancreas, and a little bit of the small intestine as well. And that's just so that they can get some really good margins and make sure that, sorry, my dog is moving around if everyone can hear that, sorry. That's just, sorry, to make sure that there's good margins and make sure that they get all of the tumor out. And so this is typically done in stage 1 or stage 2, sometimes stage 3 cancer. And then the doctors, the surgeons, when they're in there, they sort of reestablish these what would you call them, reestablish the sort of flow of things so that you're able to digest food and so that the pancreas can start to digest the food again, secreting those digestive enzymes, and then so that you have the flow to the liver as well. Next slide, please. So non-resectable cancer, sorry, is usually once pancreatic cancer has become stage 4. So I'm sure a lot of you are familiar with stage 4 cancer once it's sort of left the organ and is in the rest of your body or has metastasized anywhere else. It's no longer helpful to remove the tumor in the primary organ, at least for pancreatic cancer. I know that's not the case for all cancers. So at this point, patients are usually deemed non-resectable, and there might be some treatments, there might be some surgeries that are comfort care that are provided, but typically there's no surgery at this point. There might be some chemotherapy that's given, but usually it's palliative chemo. And the other time that there can't be surgery is sometimes, as you can see, the pancreas is very involved with those big veins and arteries there. And sometimes the tumor wraps itself around the arteries and the veins. And a lot of surgeons aren't super comfortable removing the tumor from the veins and the arteries. It can get quite complicated and it really lengthens the procedure. And oftentimes they need to bring in a cardiac or a cardiovascular surgeon, sorry. So yeah, so it can be quite complicated. There are doctors in Canada that do this, but again, you'd have to find the right surgeon to be able to do that. Next slide, please. So the pancreatic cancer statistics. So unfortunately, pancreatic cancer does not have good statistics. In Canada in 2023, 7,200 people were diagnosed, and of those diagnosed, 5,900 died. So big numbers. The five-year survival net rate is only 10%, 2% for metastatic patients, and 15 to 20% for patients that were able to have resection. And pancreatic cancer is the third leading cause of cancer death, but the 13th most diagnosed. So the statistics are hard. They're hard to see. They're hard to digest. And we know that pancreatic cancer is just one of the most deadly out there. Next slide, please. So treatments. So patients will be referred to a medical oncologist who will help determine their treatment plan. And then the treatment plan can consist of a few different things or a combination of some. So as we talked about, there's the Whipple surgery. If the pancreatic tumor is in the tail of the pancreas, the patient might need a distal pancreatectomy, which is just removing part of the pancreas that's at the bottom end instead. And to do that surgery, they don't usually remove all of the things that come with the Whipple. There's a few different chemotherapies. So in Canada, we only have 2 lines of treatment for pancreatic cancer. So there's FOLFIRINOX, which is a chemotherapy that patients can get. This is usually the first line of treatment. And then the other chemotherapy is gemcitabine Abraxane. Sometimes if patients have a certain like biomarkers or certain mutations in genes and things like that, they we'll do some sort of FOLFIRINOX combo with like a platinum-based chemotherapy, like cisplatin. So that is sometimes an option, but as you can see, there's very limited options here for chemotherapy for pancreatic cancer. There's also radiation therapy. It's not as commonly used, I don't find, in pancreatic cancer, but there's ablation therapy and also the nanoknife procedure. So these are where things are sort of like inserted, rods are inserted into the skin around the pancreatic tumor, and then they're sort of like zapped with radiation to try to shrink them. Next slide, please. So supportive treatments and palliative care. So pancreatic enzyme replacement therapy is used to help replace the digestive enzymes that the pancreas can no longer produce. So when you have your pancreas removed, there are certain juices that sort of, so before you have your pancreas removed, there are certain juices that help you to digest food. So they help to digest fat, help to digest protein, and they make it easier for your body to be able to process them. So pancreatic enzyme replacement therapy is used once somebody has had part of their pancreas removed, or if sometimes the tumor can be blocking the release of those enzymes. So patients can be prescribed, it's called PERT often, and it can be as important as chemo for patients and as effective. We had a conference in November and we're talking a lot about that every patient should be given pancreatic enzyme replacement therapy. It's very low risk. It's a pretty safe medication to take. And a lot of the time, if patients are being told, oh, just take 2 with every meal, or oh, just take 1 with a snack and 3 with your dinner, and then don't worry about the rest, it's not enough. Oftentimes patients are still having symptoms, and that leads them to believe that the pancreatic enzymes are not working, which is not usually the case. It's usually just that they're not taking enough or they're not taking it at the right time. So with PERT, it's recommended that patients take it right before their first bite of a meal. It's effective for an hour. And for anyone who is interested in learning more about how to take it and how to sort of know how many you should be taking of the PERT, we recently came out with a calculator. It's at digestthis.ca. So patients can put in their weight, their type of pancreatic enzyme replacements, if they're taking Creon or if they're taking Viocase or pancrelipase, whatever they're taking, they can put that in. They can then put in the dose that they're taking. So are you taking 25 milligrams, 10 milligrams? And then patients can go through and they can put in what they're eating for that meal or snack. So if they're having, for dinner, they're having chicken and it's prepared by being baked, or is it being prepared by being fried, or is it something like that. And then are they having sauces? So we know that like maybe ketchup doesn't have a lot of fat, but mayonnaise has a lot of fat, which would mean that you'd need more pancreatic enzymes to help support that. So that calculator, patients can put in everything that they're eating, and then at the bottom it'll tell them how many pancreatic enzymes they should take for that specific meal, and also it'll tell them how many they can take in a day. So again, that number can usually be quite high. Like patients can often take like up to 30 a day, depending on weight, of course. But yeah, oftentimes patients can end up taking more pancreatic enzyme replacement therapy than what is sort of being prescribed to them. So that's something that we're working on a lot, is to try to get the word out that it's not a one-size-fits-all treatment, and it needs to be sort of given to every patient, first of all, and then also sort of the dosage needs to be a little bit changed. Psychosocial supports. So it's really important to make sure that patients are sort of processing their diagnosis as well as they can, that they're reaching out to a social worker or a counselor, a psychotherapist, if they're finding that they're having trouble dealing with their diagnosis. It can cause depression, anxiety, lots of different things. So it's really important that patients are reaching out to who they need to be. to make sure that they're getting those supports that they need. Oftentimes there's psychosocial supports for the family members as well, and they can sort of work together to help provide these supports for anybody who needs them within the family. If you do need these supports, you should definitely have access to a social worker to get a referral that way. And oftentimes hospitals have counselors, psychotherapists. I'm not exactly sure in all of the provinces how it works with seeing a psychotherapist, but you can self-refer to those. And if you have insurance, they can sometimes be covered. So pain management. So it's important to have a pain management specialist. Pancreatic cancer can cause a lot of pain in the back and in the stomach. And if it's metastasizing, it often metastasizes to the liver and to the lungs, which can also cause some pain. So it's important to know that there is a pain management specialist out there that can help you find different supportive ways to deal with your pain beyond just being given an opioid. So yeah, there's lots of different options out there. If you're afraid to try opioids, it's also important to remember that opioids are good pain management medications, and that it is okay to take them. I recently had a patient who has been diagnosed for like 15 months, and he never took the opioids because he didn't, was scared of taking them and what the consequences could be. And when he finally took them, he started having better sleep, which better quality of sleep meant that he was able to have more energy during the day and felt better during the day. So yeah, so they are there for a reason. Make sure that you're listening to your doctor and doing that. And again, that being said, there's lots of different non-opioid pain medications. A dietitian. So a dietitian is huge for pancreatic cancer. Again, since it disrupts the digestive juices coming from the pancreas, things can change. Patients get a lot of like diarrhea. Weight loss again is a huge one. Just discomfort and pain, indigestion. It could just be really challenging when you've got pancreatic cancer. So seeing a dietitian is really, really, really helpful. Again, that's something that we recommend every patient sees as a dietitian. They can again help with the pancreatic enzymes. There's usually someone who's specially trained in oncology, and they're a dietitian oncologist, and they will help with that. There's also palliative care physicians. So again, just keeping in mind that palliative care is supportive care. It's not end of life care. So palliative care, the definition is something along the lines of helping to treat symptoms that come along with another diagnosis. So you have pancreatic cancer and you're having the pain. So palliative care would help you to either find the referral to pain management or they would give some sort of like pain management. So yeah, so just important to keep that in mind, that it's not for patients that are actively dying. It's not only for patients that are actively dying, it's also for patients that are just struggling with other symptoms. Next slide, please, Trevor. So stigmas and myths. So there's a lot of stigmas and myths out there about pancreatic cancer. We know that oftentimes patients are told to go home and get your affairs in order when they're diagnosed with stage 4 pancreatic cancer. And that's just not acceptable. We know that clinical trials are not a last line of treatment. They should be considered before you try any treatments. Trying the clinical trials and seeing, so getting a list of clinical trials that you might be eligible for. There's different programs that offer clinical trial finders. We have one on our website where you can enter in your information, such as the type of pancreatic cancer you have, the stage, any treatments that you've had. And then one of our researchers on our medical advisory committee will go in and sort of compile a list. You can tell them how far you want to travel. If you want to stay within Canada, go to the US, etc. And then you can take that list to your oncologist and take a look at the different ones, and they can help you to sort of narrow it down to which ones might be applicable, and then help with that. So it's just important to remember before you try, lots of different treatments, to find out what clinical trials you're eligible for. It can really narrow the clinical trials that you're eligible for if you've had a bunch of treatments. Sometimes you can't have certain treatments before getting on a clinical trial. So just important to remember that these should be considered as one of the first treatment options, and that it's not a last line of treatment. Again, going back to palliative care is only for patients who are actively dying. That's not, that's again, just a myth. Palliative care is for anyone who is struggling with a diagnosis and they're having side effects as a side of that. So there's usually a palliative care team that you can be referred to. They're excellent. They do wonderful work, and they can help you sort of manage any symptoms that you're having. Again, we already went over this as well. PERT should be given to patients in a one-size-fits-all fashion. That's a myth. PERT should be given to patients sort of in a take 2 to 10 enzymes with your meal or snack. So it should be able that the patient can sort of change it around and find out which one they how many they need for that specific meal or snack. So again, that calculator is really helpful. It just helps to empower patients to be a little bit more, a little bit less following, a specific number of pills. Sorry, I didn't say that very well, but I think you guys get the picture. Next slide, please. So best practices. So again, all patients with pancreatic cancer should be prescribed PERT. They don't need to have the stool test. It's again a very safe medication to take, and it should just be given to all patients. All patients diagnosed with pancreatic cancer should be referred to a surgeon. So regardless of the stage of pancreatic cancer, regardless of the type of pancreatic cancer, all patients should be given the opportunity to speak with a surgeon. Again, they might not be able to have the Whipple, or they might not be able to have resected pancreatic cancer, but there are sometimes supportive cares or things that can help ease pain, surgical remedies that can help to ease pain. And it's your right as a patient to be referred to a surgeon if you'd like to see one. Patients should be given all options for treatments that they are applicable for, including clinical trials. So again, just going back to that, sort of knowing your diagnosis and knowing what is available for you out there. In Canada, again, we have very limited treatment options. So it's important to know that in the States, they have more options. I think the States are like 5 to 10 years ahead of us medically. So it's important to know that is there. It's not an option for everybody, obviously. It's expensive. But again, it's just important to know that is there. It's important to know the clinical trials that you're eligible for, and where they are, how you would get there. Are things provided like lodging and travel costs, things like that. And then also going back to patients being told that they need to go home and get their affairs in order, like they should be offered all options of treatment, right? Like maybe they want to do palliative care, chemotherapy to give themselves a little bit more time. So again, it's not always an option for everyone. Your blood counts have to be within a certain range because you have to weigh the pros and cons, and there has to be more benefit than risk. But again, it's just important to know your options and know what's out there and available. Next slide, please. Support. So it's important to know that there are supports, and it's important to have a supportive group with you when you're going through pancreatic cancer. It can be a lonely disease. It's a more rare cancer. It's hard to find people that are also going through it. So it's important to reach out to your family and friends. It's important to let them in and let them know that you're struggling when you are, or that you need help with things. It's important to make sure that you're honest with your healthcare team and that you're sharing everything that everything you're taking medically, everything you're doing. It's important to let them know how you're feeling, if you're having symptoms. I know sometimes patients are afraid to tell their doctor that they're having specific symptoms when they're on chemotherapy because they don't want the chemo to stop. But that, like, your doctor's there to help you and they want you to have a good outcome. So it's important to tell them the symptoms. It might just be a tweak that they can make to the chemo. Again, chemotherapy is often made up a bunch of different drugs. They can maybe remove a drug or lessen the amount of certain drugs within the chemo. So definitely make sure that you're talking to your healthcare team about that kind of thing, and that will help give you better quality of life. There's advocacy organizations, so the Canadian Cancer Support Network, they're fantastic. At Craig's Cause, we have tons of programs for patients with pancreatic cancer. I know our organization specifically, we focus less on research. We know research is so incredibly important, and that there is a need for it, obviously, of course. But our organization, what we focus on mostly is the patient and helping them feel supported and helping to make sure that they have what they need while going through this journey with pancreatic cancer. We offer a support group. So there's lots of support groups out there. There's support groups specifically for different types of cancer. There's support groups for just cancer. There's support groups for tons of different things. We offer one specifically for patients with pancreatic cancer. It's every Monday at 7 p.m. Eastern Standard Time on Zoom. And it is a really, really wonderful group of people that come together. Going back to that chemo, talking to your doctor about chemo, we had a patient in the group and he was so weak and he was so tired and he was really struggling, and some of the other members were saying like, oh, I'm on that same medication, but my doctor changed it to this dose. And so he talked to his oncologist, and the next group he was sitting up and looked great and had color in his face and was, just feeling so much better because he felt empowered to talk to his doctor and his care team about his treatment. So yeah, support groups are really, really important. It's important to just know you're not alone, of course, first of all, but it's also important to, get some tips and tricks, hear other people's stories. It can be inspiring. And yeah, it's really, really important. Education. So, knowledge is power. And we definitely recommend doing your research and, getting to know everything you can. It can be hard. I know that there's some things out there that are not necessarily research-based. So just make sure that you are doing your research and that you're making sure that things are peer-reviewed, things like that, and just making sure that you're keeping your healthcare team in the loop as well with anything that you're doing that hasn't been prescribed by them. Next slide, please. So the future. In the pancreatic cancer space, our goal is to raise awareness. We want people to know that if you have 2 or more of those symptoms that we just mentioned at the beginning of the talk, that you're talking to your doctor about it, that if you have 2 or more first-degree relatives that had pancreatic cancer, that you're talking to your doctor, and just making sure that people are aware of those symptoms, of those signs, that they're aware of. It can be familial, it can be hereditary, it can be totally random. There's no sort of rhyme or reason. So we just need to make sure that people know what the symptoms are. Again, the symptoms are so sort of common, I guess would be the best word. You get back pain and you think, oh, I just tweaked my back, like it's nothing. Or you get back pain and your urine is also really dark. You think, oh, I'm just dehydrated and I hurt my back. But having those 2 symptoms together would mean that you should be going to your doctor and letting them know that you have those symptoms and getting checked. Early detection saves lives in pancreatic cancer. As soon as people are having those symptoms, it's important that they get checked, because if they don't get checked at that time, it will just continue to progress, and it's fast growing and it's aggressive. It could be the difference between going to your doctor now when you have those first symptoms, or going to your doctor in 6 months once you've turned yellow and jaundice and it's spread. So yeah, so we're just trying to really raise awareness there and make sure that people know all of those symptoms, make sure that people know that there is genetic testing out there. So if you have children or brothers, sisters, parents, making sure that if you have a genetic mutation, which can be done through biomarker testing, it can be found through that, just making sure that your children or again brothers or sisters, whatever, are being checked for those, just to make sure that if they have the same mutation, it can make them more likely to get pancreatic cancer. Research to find more treatment options and prevention. So again, going back to the treatment options that exist currently, there is only the 2 treatment options right now really for chemotherapy. There's a third one that we've tried to get back in or into Canada and haven't had any success yet, but we think that that's really important, getting more treatment options. And then screening programs. So no screening programs currently exist for pancreatic cancer. Patients can get referred to like a genetic counselor or geneticist, and they can give them a risk assessment, but it can take a long time to get in to see them. They're very busy as well, and there's not as many of them, so it can take a long time to actually get referred to them. Doctors are often hesitant to refer people if they don't have any symptoms. So in terms of screening programs, it's sort of advocating for yourself and making sure that you know what your risk is, giving your family members pancreatic cancer, or if you're having any of the symptoms, and just making sure that you're advocating for yourself, and talking to your doctor about that. So molecular and biomarker testing for all patients. So definitely it's important to get this testing done. It will sort of pick up any genetic mutations that you have. So for instance, some people have like the BRCA2 mutation, which can be common for pancreatic cancer. It can also make you eligible for, not eligible, sorry, but at risk for quite a few other cancers. So it's important to know this risk. And then the biomarker can also help determine which treatment is best for you. So if you were to have a specific mutation, you might need a platinum-based chemotherapy added to the regimen that can help. There's new research coming out for that. And yeah, it's just important. It's again goes back to knowing your tumor and knowing what you're dealing with, and how you can best be treated. Patient advocacy. So we really have been focusing a lot on hearing from patients and hearing what they need and what is important to them in treatment. A lot of the times when you're in healthcare, I don't know if I mentioned I'm a nurse. When you're in healthcare, you see sometimes that patients get treated as like numbers or things like that. But it's important to remember that each patient, is one of us. They're regular people that are, have been given this terrible, awful disease. So it's just important to make sure that we're listening to the voices of the actual patients, and that we are taking into consideration what's most important to the patient. Yeah, so we're trying to do a lot of that, and yeah, just making sure that voices are heard. I'm sure many of you have had this happen. Wait times in Canada, they're awful, and I know some places patients are waiting up to 8 weeks to be seen by a medical oncologist. And sadly, like they're dying before they even get to see an oncologist, because the cancer is so aggressive. I know that there's a patient where his dad has pancreatic cancer, and he was diagnosed about 2 months ago, and they're sort of triaging who gets to be seen by a medical oncologist, and they didn't consider him, and now it's too late for chemo. He's not healthy enough to get chemo. And so, it's terrible, frankly, and it's heartbreaking. We really need to work on lowering those wait times and the burden on the healthcare system, and making sure that cancer patients get timely care and that they're, seen in a reasonable amount of time, and that the more aggressive cancers are seen, as soon as possible. Um, yeah, it's been really hard. I'm on a few working groups, with a few different groups, that are talking about, or sorry, with a few different advocacy organizations that are, constantly trying to find, um, ways to just talk to the government. It's hard to get an appointment to talk with them or to send a letter to them and know that it's making an impact. Um, so yeah, it's, an ongoing thing that it's just gonna be something that we have to continue to advocate for and continue to get more healthcare workers, and really going at it at like a governmental level, is where the change will happen. Next slide, please. Yeah, so that is my presentation. Sorry, I know I talked fast, so I think we finished a little bit early. I apologize. But thank you everyone so much for being here. This is our contact information. My email is erin@craigcause.ca. You can always reach out to me.
Excellent, thank you. Now, if you have a question, just put it in the questions tab on the GoToWebinar on the side here. My question that I have actually is that it seems like that, I mean, with a lot of digestive cancers, I mean, everything, as you saw in the surgery slide that you had, there's a lot of just, they're so interconnected, the stomach, the gallbladder, the pancreas, everything like that. Have you ever had instances where someone says, okay, well, this looks like pancreatic cancer, but it was actually, that was actually gallbladder. I know gallbladder is extremely rare, but gallbladder, bile duct, stomach that had actually metastasized? Or do people kind of, once they have the symptoms and once they have the general idea, then is it pretty much that there's no question that this is gallbladder cancer?
Yeah, so to my understanding, they obviously have to go in and do a biopsy to see what it is. From what I know, I've never had anybody have it be sort of confused with one of the other cancers. But yeah, it is definitely an interesting one, and yeah, it's, as far as I know, it's not typically misdiagnosed. Usually, if people have Mets, they metastasize to the liver, and that's usually where they get the biopsy from. They can also do an endoscopic ultrasound, and take a little bite of the tumor there, from the pancreas. Yeah.
Mm-hmm. Gloria asks, what is the estimated cost of the biomarker testing?
Yeah, good question, Gloria. So again, we're working to get it standardized in all of the different healthcare settings so that it's just you get it once you get diagnosed. Unfortunately, with it not being standardized, it can cost anywhere from, I've heard, $2,000 to about $6,000. $2,000 being, a patient had told me that they got the like financial assistance one. So that is like the cheaper end of it. Again, super expensive. That's in Ontario. That's where I am. So yeah, unfortunately, it's not super accessible.
And then Gloria follows up, is it a cost as a patient cost? I assume that a cost that would be put on the patient.
Yes, unfortunately, yeah, it's not, in my experience, it's not covered by insurance ever. And again, getting the biomarker testing is helpful, but there's only 2 lines of treatment. So, I mean, it's hard for pancreatic cancer. It might be helpful in a lot of other cancers, and it is helpful in pancreatic cancer. It's a huge expense, for sure.
All right, we'll have about 1 minute or so left before we wrap it up. For anyone else who has a question, once again, Erin, I thank you very much for your presentation. It was fantastic. And just to wrap up, just in case there's any more questions, yes, Connie, we will be sharing the slides. We actually have a copy of the slides, and they will be shared with the email that you registered with. And Erin, one more question, just if you want to talk a bit about Craig's Cause and some of the things that you offer that you may not have mentioned yet, and just anything else that we would like to know about the organization.
Yeah, definitely. Thank you so much. So yes, at Craig's Cause, we offer lots of different patient support programs. As I mentioned, that's sort of our focus is more so around the patient than research. Stephanie, who founded Craig's Cause, her dad was Craig, and he passed away only 8 weeks after his diagnosis. During the time of his diagnosis back in 2006, Stephanie found that there were just really limited resources available, really limited information available for pancreatic cancer. And so that's why she started the organization, and that's why it's so patient focused. So we offer lots of different programs. We have a financial assistance program for Canadian patients undergoing, or sorry, not undergoing, who have pancreatic cancer. So we offer $500 or $1,000 for patients if they're in need of assistance. We have our weekly support group every Monday at 7 p.m. Eastern Standard Time on Zoom. Yeah, we love to have people come out. Again, there's lots of a core group of regular people that come out, and then we always have some new people that come out. And they're a wonderful group. They take everybody in and they help support, and they're just such a great group. I host that group, and every week is so inspiring. We have our Ask a Doctor program, so we have a medical advisory committee of different doctors. So we have oncologists, surgeons, pharmacists, dietitians, researchers, you name it, they're on there. And we can sort of triage your question, and then I send it to the appropriate specialist to get an answer. This, of course, can't be personalized information, so you can't send us like your scans and say, what should I do? But if you have a general question, we can help answer that. We have our pancreatic cancer guide program. So that's where you book an appointment with me, and I can sort of help tell you what the journey will look like with pancreatic cancer, and sort of take you through what to expect. Again, go over referrals that you should be getting if you need them, things like that. And it's also just somewhere I can offer support on a one-on-one basis. We have our support for caregivers presentation, that we offer once a month. So that's where we bring in a specialist. This past month, we just had one on Saturday. It'll be uploaded to our website soon, but we had a patient actually come in and tell their story along with his wife. And she sort of told the caregiver side of it, and he told the patient side of it. It was a really interesting presentation. He's a stage 4 pancreatic cancer patient. And then we also have our clinical trial finder, which I mentioned before. If you're interested in clinical trials, you can fill out our form, and then we send that on to our researchers and get a list of clinical trials for you within 7 days. So yeah, those are just some of our really great programs that we offer. We also have runs across Canada. We have one coming up in British Columbia in April. They're called Kicking Pancreas, which is kind of funny little sassy name. So we definitely recommend everybody to go out for that. It's you can walk, you can run, you can do whatever. If you can't walk during it, that's no problem. You can cheer on from the sidelines. Again, it's just about raising awareness. We've also helped to fund lots of research. Yeah, we hold a conference every year, lots of healthcare education. So yeah, if anybody is looking for any supports or anything, please reach out to me. I'm happy to help support in any way I can.
Excellent. Well, that's all the time we have today. Thank you very much, Erin, for chatting with us. It was a fantastic talk. And again, if you guys would like any information, it's craigcause, I believe, .ca, correct?
Yeah, got it. Yeah.
All right,
Thank
excellent.
you for having me.
Excellent. And now this is one in a series of webinars that we are having this year. Our next one is actually happening in 2 weeks. It's called Canada's Drug Listing Timelines, Opportunities for Improvement. That'll be going up on the website very shortly. So to stay in the loop about webinars, visit our website or check out our email eBlast. If you're not seeing those emails go into your inbox, please check your spam folder because we do use a third-party email service as well. Sometimes those emails get unsubscribed on their own for whatever reason. So just make sure that you are subscribed to our newsletter and on our website to not make sure that you don't miss anything happening here at CCSN. If you want to see all our webinars, you can see them at survivornet.ca/webinar or on our YouTube channel. So without that, thank you very much, Erin, and everyone have a fantastic rest of your day. Bye for now.